spine surgery, I always say that as far as spine surgery is concerned, indication for surgery should be very strict. If you don't choose the patient right, then the results are not good. But if the patient is chosen right, who actually needs and deserves surgery, result can be fantastic. For example, let's take the example of a slip disc or disc prolapse. We know that 9 out of 10 disc prolapse are going to settle down on their own. If we start doing surgery for each disc prolapse that happens, is not fair, is unethical. Patient who does not settle with non-operative treatment after disc prolapse, or he has lot of weakness in the legs or arms depending whether the disc prolapse was in neck or in the lower back, or somebody who who's developing problem passing urine because of pressure on the nerves. These are the definite indications or candidates for disc surgery or microdiscectomy. We use microdiscectomy for dealing with disc prolapse, in which patient can get up the next day and walk the next day. Other indications which are important indication for spine surgery are, for example, elderly people where spinal canal, in which the spinal nerves are traveling, becomes narrow because of extra bone formation or extra ligament formation or flesh formation, what is known as spinal canal stenosis. In that, patient has back pain, pain going down the legs, patient cannot walk a long distance and gets heaviness or pain in the legs or numbness in the leg. In these kind of situations, again we do decompression and stabilization of the spine. Again, it depends whether one level is involved or more levels are involved. We prefer to do a minimally invasive decompression and fixation, especially if only one level is involved, what is known as MI-TLIF or minimally invasive interbody fusion, because the cutting of muscles is less, there is less blood loss, rehabilitation is faster in minimally invasive surgery. But if there are more segments involved or in certain type of situation, we would do open surgery as required. Results of decompression for spinal canal stenosis are very good. Then comes some young people have deformities in the back, for example, like a C curve, scoliosis, or if you see from the side there is a curve hunch back or kyphosis. So if the deformity is cosmetically not acceptable, mind you, I am saying cosmetically not effective, not acceptable, it is not for any other reason, then a corrective surgery can be done to make the spine straight. And now we use a modern method of doing that, in which we do what is known as a segmental correction. We put screws at different levels and correct it by what is known as a segmental correction. And then there are situations, for example, in elderly people in which they can get collapse of the bone because of osteoporosis, what is known as a vertebral compression fracture. Most of these will settle down on their own, but should they not settle? Should it be very painful? Should an elderly person not be able to walk because of pain, because of these kind of fractures? Then we can inject cement into that vertebra, what is known as a vertebroplasty or a kyphoplasty, and this is done under local anesthesia and patient can get up and walk. But I would like to emphasize again that this should be reserved for patients who do not respond to non-operative treatment. But the results of this, those who have not responded and have got this surgery done, are fantastic. Patient can actually get up and walk. And then other surgeries are, for example, if there are spinal infections, tuberculosis, sometimes it affects and presses the nerves, and sometimes patient can lose power in their legs or weakness. So these are the situations where one would do spine surgery. And then spinal tumors inside the spinal canal have to be taken away, or spinal cancer or things like that sometimes need surgery, and these are done.